now let's get to cardiac tumors. So let's first start by looking at this MRI. So when you're shown an image on your exam, do not freak out. Take a time for yourself, take a second, and orient yourself with the image. So obviously we're looking at the cardiac chambers with a particularly unique structure delineated here in our most posterior. So this is the anterior, this is posterior, this is the patient's left, this is the patient's right. This is a CT scan, right? So we know that the left atrium is the most posterior chamber of the heart. So this is probably left atrium, right? Of course it is, and there's something in it. What could potentially be in this left atrium that has a huge mass-like presentation? Considering the slide says cardiac tumors, that's probably the answer. But yes, you need to think about this. Now the chance of them showing you an image like this may not be the most particularly high yield, but it's important to know everything about cardiac tumors because they could potentially show you an image and ask you a question. Now, what is the most common tumor to find in the heart? It is a metastatic tumor, usually melanoma or lymphoma. So when you think about cardiac tumors, melanoma and the lymphoma are the two that you should be thinking about if you're worried about some sort of metastasis. This is an incredibly high yield fact because it's an exception to most rules, and test question writers love things that deviate from what a logical mind would expect. The most common primary cardiac tumors in adults. So, in the adult population, you definitely want to be worried about myxomas. And the most common primary cardiac tumor, as in they arise from cardiac tissue, in children, you need to be worried about rhabdomyomas. What do you need to know about myxomas and rhabdomyomas? Well, what does this word mean? These are usually benign tumors originating from mesenchymal cells. Mesenchymal cells are also the cells that give origin to the type of tissue that comprises the heart valves. So this makes a lot of sense considering the name myxo means mucus and the name oma means mass. So this is a mass that produces something mucousy. Now you can make this connection with the fact that mesenchymal cells differentiate into tissues that make heart valves that are covered with mucopolysaccharides. Where would we even worry about seeing a myxoma? The most common place for these mesenchymal cells to start proliferating like crazy is near the fossa ovalis in the atrial septum. Remember, the fossa ovalis is a remnant of the foramen ovale. So these are big round masses that sit on a peduncle. It looks like this. So this is a peduncle or a stalk. And this is our big round mass of myxomatous tissue. So basically, it's like a big wrecking ball in the atria. So imagine this is interatrial septum, and this is our chamber. This is the left atrium we were looking at on the CT scan. So think about a vignette. Miley Cyrus comes in because she just passed out in the middle of her concert. Vital signs are stable, she's in no acute distress, labs are normal, including a negative urine drug screen. The only abnormality on physical exam is you hear a murmur that kind of sounds like mitral stenosis. So you're thinking, does she have mitral stenosis? But her medical records indicate no history of any heart problems when she was last seen a year ago. What is she suffering from? She is suffering from a myxoma in her left atrium. So remember, here is our tumor attached on a peduncle. Here is the mitral valve. This is our posterior leaflet. This is our anterior leaflet. And this is the left atrium. The reason that we hear a murmur of mitral stenosis is that this tumor will fall and occlude the opening between the left atrium and the left ventricle, creating a stenotic opening. There's nothing actually wrong with the mitral valve. This tumor is like a wrecking ball inside of the left atrium on a thin stalk. It is just crashing into the mitral valve when it opens, and it decreases the opening ability of the mitral valve, and therefore there will be less blood passing into the left ventricle. That is why she passed out. The impeded filling of the left ventricle from this tumor means that we had a decrease in cardiac output, and that led to a syncopal episode. I don't know if you'd consider Miley Cyrus an adult yet, but that is the age that you would be most worried about a primary cardiac tumor being a myxoma. Now what about the other tumor that we talked about, the rhabdomyoma, right? So rhabdomyomas are the ones that you'd be worried about in the pediatric or children population. It is associated with a super high yield disease in kids, And the disease I'm talking about is tuberous sclerosis. Can you tell me the clinical presentation of a kid with tuberous sclerosis? They have hypopigmented ash leaf spots on the skin. They have cortical, so in the cortex of the brain, and retinal hematomas. Remember, hematomas are tumors that comprise of all the types of cells that you would expect to normally see in that area of the body. And then rhabdomyomas are obviously going to be present. So that is the type of tumor that we were just talking about. And there's an increased risk for astrocytomas. So this is your clinical presentation that you will have in a vignette if you get a question about a cardiac tumor with a rhabdomyoma seen in the pediatric population. The vignette will probably include some sort of biochemistry tie-in with things that you should know about tuberous sclerosis, which are presentation of hypopigmented ash leaf spots, hematomas, particularly in the cortex and the retina, and rhabdomyomas with an increased risk for astrocytomas. Also, do not forget about the classic skin presentation of adenoma sebaceum, in which it is classically described as an acne-like rash on the malar area of the face. So, what renal pathology is associated with Enoch-Schonlein purpura? This is immunoglobulin A nephropathy. I know this is kind of out of left field, but that's the way that you need to practice thinking for your Step 1 exam. The questions come in random distributions. So I put this here to test us, to kind of shift gears and see if we can think about something else. Now, this is an incredibly high-yield disease for you to store in your brain. Enoch-Schonlein purpura usually develops after a kid has an upper respiratory infection, which was one of our previous risk factors for the development of another situation, which was what? Which is the serious pericarditis that occurred usually after upper viral respiratory infection. So I think about Enoch-Schonlein purpura as the immune system gets all fired up and there's just way too much IgA, hence immunoglobulin A nephropathy. There's way too much IgA created in response, and what is unique about IgA is that it will not be the only thing increased. You'll also see an increased number of complement protein C3 production. The IgA deposits in the mesangium and the glomerular basal membrane. Anytime you deposit antibodies anywhere, you will activate the complement response and you get damage. So why are the C3 protein levels of the complement system normal in patients with HSP, or increased? Well, remember, there was an increase in C3 production to begin with. We will have normal levels of C3. So those mesangial cells are also modified smooth muscle cells in addition to having some phagocytic capabilities. They can actually be induced to produce C3 when they interact with glomerular proteins coded in IgA antibodies. And this is only a local production of C3. So there's no change in the levels of the circulating C3 that are measured and will be given to you in your vignette as a normal C3 level. Now, Kussmaul's sign is an important physiologic concept that will help us review. So remember when we talked about taking a deep breath in, you increase the expansion of the thorax and the diaphragm, and you create a significant amount of negative intrathoracic pressure. And this causes a kind of a pull on any sort of vessel or structure within the thorax, allowing an increased compliance of whatever structure we're talking about. So if we're talking about the pulmonary vasculature or any of the cardiac chambers, they're kind of distended, and it increases the ability of them to take in volume, so that ordinarily jugular venous pulse will drop in inspiration due to the expanding thoracic cavity and the increased volume afforded to the right side of the heart because we're in diastole taking a breath, and it increases the ability of that chamber to take on blood, including because of the changes that are happening in the pulmonary vasculature, right? Now this results in a decrease in the jugular venous pulse because the blood will more easily flow into the right side of the heart at a lower pressure. Now Kussmaul was really smart and observed that when something is blocking the transmission of the inspiratory negative intrathoracic pressure, such as excess fluid or blood in the pericardial sac, there is a slight difference in the physiology that you see. So that when we have inspiration, there is no transmission of negative intrathoracic pressure. So that expected increased filling on the right side of the heart does not occur due to limited expansion of the right atrium. So let's kind of visualize that. So if this right atrium is not able to accommodate blood that's being returned to it per unit of pressure, then it will quickly reach its maximum ability to take on incoming blood. The pressure begins to back up into the superior vena cava, and therefore also the jugular veins, which is J veins there in the diagram. So you can see Kussmaul's sign in any condition that causes compression of the pericardial contents, such as a constrictive pericarditis, right? Makes a lot of sense. And the same situation can occur in a restrictive cardiomyopathy, because both of these are restricting the heart from expanding. So if you imagine your heart is in 4 chambers, it cannot expand due to either some sort of constrictive or restrictive process going on. In addition to that, we can have right atrial or right ventricular tumors presenting with Kussmaul's sign, because there is a tumor in this chamber or a tumor in this chamber causing decreased ability to take on a specific volume of blood, so that there will be decreased ability of the blood to flow under normal pressure from the jugular vein to the superior vena cava and into our right atrium. This increases our jugular venous pulse, and clinically you can see jugular venous distension potentially with more notable jugular venous pulse due to this backup of pressure.